Well, I started my OBGYN practice in 1986. I graduated from the Medical College of Wisconsin, and I started to get involved in hormone replacement therapy in 1996. I was in my office, and on a Sunday I had a stack of charts that had breast cancer, and I tried to compile a prerequisite as to why these patients had breast cancer, and what I came up with was unopposed estrogen therapy. So for 2 years, I established a Menopause Institute, and for 2 years I researched the world literature at that time on hormone replacement therapy, etiology of breast cancer, and came up with the formulation that was the precursor to what I use today. Most people think hormone health is where your hormones are healthy. But in my experience and my research shows me, most importantly, it's more like the yin and yang. It's the balancing of hormones that really produce the effects that you want. Hormone health or hormone therapy it looks simple, and a lot of people are doing it very simplistically. However, it was very complex. It involved a lot of different formulations, a lot of different dosages, a lot of different hormones that all work together in the body to create what I would call a balance. And that balance is what we're looking for. Hormones are the central function of every single system in your body. So when you have a hormone imbalance or hormone deficiency, it affects everything. And people who are experiencing hormone deficiencies can attest to that. And doing this for 25 years and seeing literally hundreds of thousands of people, I think I've established a theory that most people don't even attribute a lot of their symptoms with hormone deficiencies or hormone insufficiencies and out of balance hormones. So when we begin to discuss with each patient their specific situation, they feel as if we're taking care of them that no one else has done before, and that is asking pertinent questions as to their complete history going back to childhood. And dealing with issues that they haven't even seen before as related to the changes of hormones, especially women who have, for example, progesterone deficiency their whole life. And that includes endometriosis, infertility, and PMS, and ends up, unfortunately, 25, 30 years later, needing, finally, the proper therapy. For men, a lot of it is related to testosterone, but there are other hormones very important in balancing. And people are amazed when I tell them that estrogen surplus in men can actually cause benign prostatic hypertrophy, which is enlargement of the prostate gland. I think that what drives most patients to seek treatment is usually partner relationships, is whoever they're with is telling them that they're either changed for the worse or they're not able to perform and function in an intimate relationship. And that includes men and women. People feel bad about themselves when they cannot perform both emotionally, intellectually, as well as physically in a relationship. We have many professional women and men who come to me and say they can't perform their job. I remember a judge who told me that she couldn't remember what was going on in the courtroom because she was having foggy thinking from progesterone deficiency. And we cured her for that, and so we saved her career. So it is really dependent on at what point does it affect your performance, whether it be personal or professional. Well, whenever you look at a fear of anything, fear comes from an emotional base. So we need to replace the fear with knowledge, information, and our website is full of information that has been very helpful for our patients. We should never make decisions based on fear. Fear is not a good motivator, in my view. We have to make rational decisions based on risk and benefit. The advantage of coming to someone like us is that we have so much experience that probably we've seen what you have hundreds of times. And we have patients with autoimmune disease problems that can go along with hormone deficiencies. We have patients with cancer that go along with that. We try to focus on the immunological system, not only just the endocrine system. The adrenal gland is a very important aspect to deal with when you're dealing with sex hormones. So when we try to integrate our program to the individual person, we do have a fairly structured paradigm that we work with, but then when it comes to therapy, it's very specific to the patient. So even though we all have fears, I think the replacement of fear with knowledge is the key. Some of the most common are dryness of the skin, eyes, and vagina, sexual issues, inability to perform sexually, or inability to have an orgasm. They come to us with a bone scan that shows bone loss, osteopenia or osteoporosis. They have fatigue, they have weight gain, they have loss of muscle mass. Patients who are long-term deficient will have symptoms of autoimmune problems, immunological deficits, which are exacerbated by lack of proper hormone balance. Mood changes, anxiety, depression, insomnia are very common. We have rare cases that will come in with all of the symptoms. And unfortunately, a lot of them are treated with psychotropic medication, which is really unfortunate. I think now, I remember I've been doing this since 1996. So there were phases that came and went, fads that came and went. And they're not based on science, they're based on marketing. So a lot of these methods that are being used are not going to be used in a few years as people are getting very dissatisfied because they're not based on science. They're based on a company wanting to push a product. So I stay away from all that. I tested from 1994 to 1996 for 2 years, hundreds of patients to establish which form of delivery system is the most consistent in terms of establishing blood levels so that I can utilize chemistries so I can determine what the patient needs in the beginning, but also to help us understand what X dose will be and Y blood level. And so that took us about 2 years to figure that one out. We've made some changes since then. We've added a lot of nuances to it, but basically that was my approach to it. So when a cycling woman has X amount of hormone in a month, we tried to figure out what it was that she was experiencing in that month and then try to divide that over the month to make it consistent, especially when it has to do with the fact that women do not want to continue to menstruate in their 50s and 60s. We start off with trying to establish the minimum need to replace symptoms. And I have this what's left syndrome, which means after we give them the initial therapies, we have them come back usually within 2 months and see what's left and see how we can mini manage, because I believe that these little tweaks that we can do can really maximize the benefit of our therapies. That takes individualism, but also it takes a lot of experience. So we try to figure out what it is that they need initially, and usually it's pretty right because we have so much experience. I have over 1 million patient months under my belt. So to me, I can pretty much figure out the formulations fairly quickly. Our staff now knows how to do that because we do have a protocol that we do follow. So when there is too little of a hormone or too much of a hormone, then symptoms will not be relieved. And so that just takes a lot of clinical experience. People are coming into this field because they think that it's very simple. And a simplistic approach would be the pellet, for example. Now, the pellet may be good to make women feel better by having a boost of testosterone, but is not a balanced therapy that I can see, or a long-term management, because it does not maintain an even level of hormones over a period of time. In fact, there's an explosion of hormones in the beginning and then it tailors down. And I find we have probably 500 patients who have been on the pellet who experience tremendous symptoms of withdrawal on the way down. And they need more and more testosterone to maintain until then they develop the side effects of too much testosterone, which is the androgenation of their body, which is not what they want. Well, when I first started in the 1990s, creams were the thing. Um, there was a lot of material out, a lot of people were using topical creams. I found it to be inadequate and ineffectual in manifesting the correct prevention of certain disease processes, including breast cancer, uterine cancer, and osteoporosis. So that wasn't, for me, enough just to, quote, take care of hot flashes. Almost anything can do that. There's a lot of supplements on the market that are estrogen-based, and mainly from herbs that contain estrone, which is unopposed estrogen, which again was the motivator for me not to continue to use, at that point, unopposed estrogen. So that didn't work. So when I researched the world, there was, especially in Europe, the usage of Troche, which is a gel or a wax-based that you can impregnate exactly the amount of hormone in every square, and it's usually in a packet of 30. And you can put more than one hormone together, which I liked because it was economic. It made sense because most of our patients have been on it for years. And so once they get on it, they are expecting to pay a certain amount. And it really cut the cost of the therapy to about 1/3 of taking 3 or 4 different substances that contain each one hormone. A cream, a pill, an injection. All of those things to me was due to lack of knowledge about how it works. So the Troche fit into that category. Plus, people don't mind putting something in their mouth. People chew gum, they have lifesavers. People are used to that. So putting something in the mouth to dissolve made perfect sense. And the transbuccal absorption, which means the absorption through the inside of your mouth, works excellent for hormones. So we knew that. And so it made a good fit, and plus you can flavor it. We have, our pharmacies have a choice of about 50 flavors now. And you can sweeten it, unsweeten it, so it really does make sense to individualize therapy, to have an ability to put in whatever hormone you want in an exact dosage, and technically administer that on a daily basis to be exactly the same. So the Troche made perfect sense. No other method that I had found, or is there in this time period, able to do all of that for such a economic way of distributing hormones. Well, the first thing is that people put hormones in one group. So when they say hormones cause breast cancer, well, unopposed estrogen definitely stimulates an existing breast cancer. Our incidence of breast cancer is almost 0. Because it's a balanced hormone therapy. We monitor it, we know exactly how much we're giving. We know that we give levels that are actually below what a normal woman would have during her whole life. So we do consciously monitor and give the least possible hormone to take away the negative side effects of hormone deficiency, and also give the protection for breast cancer, and the protection from uterine cancer, and the protection from bone loss. So I think that the myth that hormones causes cancer makes no sense to me at all, and I haven't seen it. Everyone knows that if you sleep better, your immune system is enhanced and you get less sick. Well, our patients are most always having sleep disorders secondary to hormone deficiency. Once they sleep well and they sleep better, solid sleep, increased REM sleep, their immune system has a chance to recover. So they do better in developing their own immune system to fight the cancer cells that are being produced in the body. So the myth that hormones causes cancer in general, specifically breast cancer, we just don't see. I guess if you use unopposed estrogen therapy, or a therapy that does not contain a proper balance, I think there is a risk that is not going to be favorable. Another myth that I've seen is that it's very expensive. It's not true. It depends on where you go and how the person who's administering it, what his or her experience is, to keep the cost down, because it is a long-term commitment. You know, it doesn't mean that you start hormones in 3 years and then stop it and everything is going to be fine, because the issues of hormone deficiencies and imbalancing goes on for the rest of your life, especially when it has to do with muscle loss and bone loss. Today, many women want to maintain their muscle mass, not just men. Women want to maintain it not only because they look good, they feel good, but also for weight management. So the myth is that if you take testosterone, you're going to develop a male body, which is just not true. It's all dose related. So we see a lot of patients who are afraid of testosterone because they think they're going to become male looking. And of course, they don't know that women have been producing testosterone from their hormones since they were basically in puberty. Well, most men don't really know what their testosterone level is. They have not been checked. So a lot of men who come in with finally symptoms that they think are related to low testosterone, and we ask them, you know, how come your family doctor or urologist didn't check you? And they say, well, because I'm too young. That's a myth. A lot of younger guys especially have very low testosterone levels, and it affects them because they think there's something wrong with them, but all it is just a hormone deficiency. What I also see is that a lot of men do not know that you can replace it with low dose testosterone and you can feel great. You don't have to be overtreated. It's not necessarily dose related. So we use the least possible dose of testosterone that will give you the maximum benefit. So we're not looking to make bodybuilders out of the men either. We want them to be normal looking, but also it helps them in the area of weight management. Speaking of that, another myth is that you gain a lot of fat. Now, if it's done improperly, where estrogen is not monitored by the practitioner, testosterone is converted to estradiol. Estradiol does increase body fat in the midsection. So if you have high estradiol from testosterone therapy, yes, you may end up with that pouch that you don't want, which is unappealing and also not healthy. So we do monitor that and make sure that the estrogen level is properly treated with an anti-estrogen. Another myth is that men believe that sexuality is the key driver. You see advertisements everywhere about ED and come in and they get testosterone and everything is fine. In my experience, that is not the most common complaint. That is probably number 4. We see the most common complaint of lack of energy, fatigue. Second one is lack of muscle. They just lose their muscle, especially upper chest and biceps. And the third thing is usually sleep disorders and morning stiffness. Then the libido comes in and the erection issues come in, but it usually is not the driver for most of our patients who come in. Now, that usually is what finally brings them in. But when you get the history, they find that they've been suffering from low T for a long time. Well, we're here for the long term. We are the long-term relationship with our patients. We are not the one-nighter. We are here to correct the deficiencies, balance the hormones that are necessary for good health. We focus on proper nutrition. We focus on weight management. We focus on interrelationship issues. We focus on the presence or absence of post-traumatic stress disorder. We have a psychotherapist on staff that helps us with that area. We try to deal with the whole person. And I think that because hormones are so integral in our functionality, that we really have to approach it that way. Approaching it just as a way to make money, to me, is a travesty. And that's what I see a lot of. When people come from other places and they're being charged a lot of money and they're getting very little for their money. And to me, that is not what we're about. We've been doing this now for 25 years and we are growing rapidly. And we expect to continue to grow, to give quality information, quality service at an affordable price for everyone.